Morning, everyone. Thank you for joining. We'll just give it another couple of minutes for people to continue to join the session this morning, and then we'll get started. Alrighty. So good morning and welcome to the second day of the Carer Knowledge Exchange Research Incubator for 2026, recognising, respecting and reimagining 50 years of learning from carers and shaping what comes next. My name is Melissa Docker and I'm the Acting Executive Manager of Policy Development and Research here at Carers New South Wales, and I'm pleased to welcome you today to the session. This event has been developed in collaboration with our guest speakers, and it is wonderful to see many of you joining us for today's discussion. Before we get started, I'd just like to open the session by acknowledging the traditional custodians of the lands on which we're joining from today. For me, that's the land of the Gadigal people of the Eora Nation, and I would like to extend my respects to elders past, present and emerging, and to anyone Aboriginal or Torres Strait Islander joining us today. So please feel free to add the lands that you're joining from today in the chat. Please note that today's session will be recorded and shared for on-demand viewing. We ask that the first hour of the event, everyone who is not part of the panel, please mute your microphones and turn off your camera so we can focus on the presentations and panel discussions. We recognise that we have many carers and others with lived experience joining this session. If you hear something that causes you distress or that you need to talk to someone, we have a wellbeing officer available online who you are welcome to contact. Further information about how to do so will be posted in the chat. This event brings together participants from diverse backgrounds, areas of expertise, and our aim is to create a positive learning environment for all participants that is based on kindness, respect, and all perspectives, and where all perspectives are valued. You're welcome to add questions and comments in the chat throughout the session and use the Q&A function to put in questions for later on. For some of you, this may be your first introduction to the Carer Knowledge Exchange, or CKE. The CKE is a research translation project led by Carers New South Wales and funded by the New South Wales Department of Communities and Justice. This year marks both the 5th annual research incubator and the 50th anniversary of Carers New South Wales. Over the past 5 decades, carers' voices and lived experience have helped shape important conversations across research, policy and practice. And this important event provides an opportunity to reflect on that progress while also looking ahead at what needs to still change. Delivered over 3 days, the Research Incubator will bring together carers, researchers and policymakers and practitioners to share knowledge, exchange ideas and learn from one another. Today's sessions are centred around a theme, understanding the present, and will explore current challenges, evidence-informed approaches and practical innovations across the carer space. This morning's sessions, policy and practice innovations, carer support initiatives across systems and policy areas, will focus on what is currently working well for carers, what is changing across systems, and where further improvements are needed. We'll aim to highlight how research has influenced policy and practice change and how policy and practice informs future research opportunities. As we proceed today, please feel free to post your reflections, comments, and questions in the chat. If we have time at the end of this panel session, we will address some of the audience questions. I'd now like to introduce our panelists, and we'll introduce all panelists, and then following that, we'll have some short presentations as the panelists speak to some of the innovations they've been working on. Tia Covi is we have Tia Covi joining us. Tia is a social worker at the University of Sydney, trained as a social worker at the University of Sydney and spent her first 10 years working alongside human rights lawyers at the Guardianship Tribunal, promoting the rights of adults living with disability. Since joining Central Coast LHD in 2006, Tia has held strategic and quality improvement roles across child protection, cancer services, and carer support. She has been the manager of the Central Coast Local Health District Carer Support Unit since 2022 and was seconded to the New South Wales Ministry of Health Patient Experience Team last year to contribute to the development of the visitation policy. Tia also brings lived experience as a carer, having supported family members through cancer and motor neuron disease, while working and raising 3 beautiful children, and understands firsthand the realities of balancing care work and family life. Welcome, Tia. Professor Iva Strnadova is a professor in special education and disability studies at the University of New South Wales. Her research focuses on improving the lives and well-being of people with disabilities and their families, particularly with intellectual disabilities and autism. She is widely recognised for inclusive and advocacy-based research approach which supports self-determination and actively involves people with intellectual disabilities in the research process. Welcome, Iva. Our next panelist is Myra Hamilton. Myra is an ARC Mid-Career Research Industry Fellow in the discipline of Work and Organisational Studies at the University of Sydney. Her research focuses on gender, work and care across the life course, exploring how workplace and public policies can better support wellbeing and financial security for carers and families. With almost two decades of research experience, Myra works closely with government, industry and community organisations and regularly contributes to public discourse on topics including work and care balance, parental leave, ageing and generational relationships. Welcome, Myra. We also have Holly Hoskisson joining us today. Holly has an extensive experience in the design and delivery of needs level service across the non-profit sector with a strong focus on unpaid carers, children and families and underrepresented communities. They have led diverse teams and are particularly passionate about intersectionality, health and social care integration, policy implementation and women's leadership. We welcome Holly to the panel. We'll now move on to some brief presentations and a panel discussion where our speakers will share practical examples and insights while exploring opportunities to identify and strengthen scalable models that better support carers and communities. So we'll start by getting panelists to share a recent innovation that has made tangible difference for carers and what's enabled its success. So we will start with Tia.
Thanks so much, Mel. I would like to say that I actually feel incredibly privileged to be the person that's actually speaking to this new New South Wales health policy. It's a health policy about visitation and it's called Caring Together, Welcoming Visitors. After years of consultation, feedback and refinement, this policy was launched on the 5th of May this year, aptly during Human Experience Week. It was also launched at Sydney Local Health District, a district whose Chief Executive, Deb Wilcox, played a significant role in getting this policy started and where strict visitation hours had already been removed in favour of more flexible, person-centred visitation. I would also like to acknowledge that I'm coming to you from dark and young land on the Central Coast, and I would like to pay my respects to Elders past, present and emerging. I would also like to acknowledge those with lived experience in the room today. I recognise that for some of you, experiences within the health system have been difficult, and this work may bring up emotions and memories, including from during COVID. This policy reflects a commitment to more compassionate, inclusive care and to improving experiences for patients and those who support them. Why this work matters. Evidence consistently demonstrates that involving families, carers and other supports contributes to safer, higher quality and more compassionate care. Connection is not simply beneficial. It is fundamental to effective healthcare delivery. However, the pandemic highlighted how quickly this connection can be constrained. Visiting restrictions resulted in significant distress and isolation for many patients, families and carers. Healthcare restrictions Healthcare staff were often required to navigate complex and ethical challenging situations, frequently without clear guidance or consistent principles. Across the system, there was a consistent recognition that disconnection had tangible impacts on care, quality, safety and well-being. These findings were reinforced at a national level, including through the Australian Human Rights Commission Collateral Damage Report, which emphasised the importance of maintaining connection, dignity and support, even during periods of crisis. Advocacy and shared understanding. There was also significant advocacy from carers and consumers. Through the Health Consumers New South Wales Consumers Leaders Task Force, visiting and family presence were identified as critical priorities. The advocacy brought forward not only policy considerations, but also the lived experiences of individuals directly affected. From this, a shared understanding emerged that connection with family, carers, and other supports must be intentionally embedded in the delivery of care, not only during periods of crisis, but as a fundamental element of everyday practice. Development and approach. A statewide advisory group was established, bringing together consumers, carers, including a carer whose son had an assistance animal, clinicians, operational leaders, non-government organisations such as Carers New South Wales, and Mel was very much a part of our committee, and policy teams. The group was co-chaired by a carer representative, Layla Hallam, and Chief Experience Officer Anne-Marie Hadley from New South Wales Health. Through extensive engagement and ongoing consultation, the policy reflects a considered balance of patient and staff safety, infection prevention and control, cultural safety, equity, and the diverse needs of different healthcare settings. The resulting framework adopts a principle-based human rights approach rather than relying on prescriptive rules. This includes a more flexible approach to visitation, whereby, wherever possible, patients are supported to guide who may visit them and when within safe and appropriate boundaries. Why this matters? At its core, it's a shift from local health district and staff-controlled visitation to a human rights-based approach, where patients direct who can visit and when, subject to safety. In simple terms, who matters to the patient matters to us, where admitted patients and residents can receive visits from people they want to see where it is safe, and people attending appointments can be accompanied by a family member, friend, or advocate if they choose. It explicitly recognises that family, carers, and support are not separate from care. They are part of how care is experienced, understood, and delivered. In the words of carer Michelle, "My daughter had a baby just a few months before Mum was admitted. Being able to bring the outside world into the ward, having little Ayla perched on her knee, watching her smile worked wonders. Honestly, it was better than any happy drug she could have had." For me, the most significant shift introduced by this policy is actually how a visitor is defined. This was an area of substantial discussion and consultation. Some parents and carers considered, they expressed concern that the term visitor risked minimising their roles, while others saw it as an important opportunity to explicitly recognise and articulate their roles within the policy. There were also concerns that a broader focus on friends, neighbours and well-wishers might inadvertently elevate their visibility above guardians, carers and parents. Through this process, a deliberate decision was made to use this as an opportunity to acknowledge the full range of individuals a patient may choose to have present. Importantly, it also reinforces the need for staff to clearly identify, recognise, support and partner with those who hold legal and legislative responsibilities, such as carers. The policy further encourages staff to take an inclusive and holistic approach, promoting consideration of whether a patient may wish to be visited by a spiritual or cultural advisor, or even a pet. Accordingly, for the purpose of this policy, a visitor is defined as anyone the person themselves identifies as important to them. This includes guardians, carers, parents, partners, family, kin, friends, elders, spiritual advisors, community leaders, and others important to the person, such as assistance animals and pets. We also recognise that in practice, these decisions are not always simple and often involve balancing competing priorities. We acknowledge that for staff, this can be challenging and at times may feel uncertain and complex in real-world situations. Safety remains paramount. Infection prevention and control is essential. Security must be maintained. However, this policy promotes a shift in approach, encouraging consideration not of whether access should be declined, but how it might be facilitated safely. This includes, and it's explicit in the policy, providing visitors with clear and appropriate information to support safe participation in care, offering alternative means of connection, such as virtual engagement where in-person visitation is not possible or not desired by the patient, ensuring that any restrictions are proportionate, least restrictive, time-limited and subject to regular review. Where limitations are necessary, there remains an obligation to preserve and support connection wherever possible. For staff, the policy establishes clear expectations, shared language and organisational support to guide decision-making. It is further supported by a dedicated SharePoint resource, providing access to evidence-informed guidance, as well as examples of effective practices implemented across services. In closing, I'd like to introduce you to Barry and his chosen family member, Crusher. I was lucky enough to lead a project called Pets Are Family Too with the Public Health Unit on the Central Coast. From the beginning, I wanted the Carer Support Unit right in the centre of this work because carers were often the ones quietly making these visits happen. And we'd often hear from them that they felt like they were doing something wrong, like they had to sneak the pet in just to bring some comfort and joy to the person they cared for. We wanted to do this so that the change would be safe, visible and supported, so carers could feel confident, recognised and even proud of the role they were playing in bringing connection, joy and purpose into the hospital environment. As you can see, the work started in COVID at a time when connection was so limited, and it has since grown into a clear and robust process that supports personal pet visits for patients in our Central Coast facilities. Now, Barry had been in hospital for 6 weeks after a stroke. His family and friends had been visiting, and staff had been doing everything they could to encourage him to go to rehabilitation, but nothing was working. We were told he was deteriorating and that he had started saying he didn't want to keep going. Then we found out about Crusher. Arrangements were made and Crusher went through the COVID checks like everybody else, up the lift and onto the ward. The first thing we noticed was a shift in the space, staff smiling, a sense of energy, other patients stopping to watch and ask questions. Next slide, please. In the time it took me to speak to one patient, Barry, a man who hadn't got out of bed in those 6 weeks, managed to get himself safely onto the floor to hug Crusher. He was crying tears of joy, feeding Crusher water, completely present in that moment. This was someone who had lost motivation, who had said he didn't want to be here anymore. And in one visit, Crusher brought him back. I walked over to Barry, he reached out his hand, held my hand and in broken speech said, "When can I go to rehab? I have to get home to Crusher." And he did. He went to rehab and he went home to his son and to Crusher. This is the power of a visitor, whether they have 2 legs or 4. Thank you.
Thank you so much, Tia. Thank you for sharing. And I will now hand over to Iva.
So I would love to today talk about a substantial program of research that is absolutely grounded in co-production. And by co-production, I mean working together with people with intellectual disability as researchers, as change makers, as designers of solutions. This big research program consists of 2 key flagships, if I may call it that way, and that's a Gene Equal program and My Health Choices, My Way, which is a new extension of Gene Equal. And what we are focusing together on is making healthcare inclusive, person-centered and respectful for people with intellectual disability, who shared with us that their experiences have been very depressing. They often get a talk to only to the healthcare professionals always talk to their support persons, for example. Their capacity to provide answers is doubted. The information that is provided to them is not accessible. And as we know, thanks to the National Roadmap for Improving Healthcare for People with Intellectual Disability, there is twice as likely for them to die of causes that were not necessary and to experience the premature death and many more hospitalizations. So the healthcare is very inequitable for this population of people. And so we really felt very passionately about making a difference. In our inclusive research team, we have created many innovations, but I would say that the innovation not are as much as the products, though they are really important, or the outputs, but the innovation is the way to working. So we work together side by side with people with intellectual disability in our research teams. They are co-leaders, they are co-deciders. One of the biggest success lately, and you can scan the QR code and have a look for yourselves, is the Easy Read booklet that was created by people with intellectual disability, called Life with Intellectual Disability. And that came because we found out that there is nothing accessible that would explain this condition. Furthermore, many of the explanations are very deficit-based, focusing on what people can't do, not what they can do. So this is a very strengths-based booklet put in Easy Read, which is the principles I'm using on the slides. You have on right side a plain English text, and on left side visuals that accompany it. And the team that has developed this booklet also provided a voiceover that is available on our website. It has been consulted with further 40 people with intellectual disability, and they made changes again. And the final product is making a big difference. Another example of the innovation, we have just recently released the Gene Equal Choices Toolkit, which are now available not only on our Gene Equal website, but also on the website of New South Wales Ministry of Health. We've co-produced this together with people with intellectual disability and with the healthcare workers and the ministry. And these are resources that make accessible making decision whether I want to make a genetic appointment and genetic test or not. And again, until now, there was no accessible way of explaining the whole process, and people told us that that's wrong. They are actually interested in genetic healthcare, and they don't know how to access it, and they don't understand, for example, the consequences of saying yes to tests, how do I get the results, and so on. And so we developed a beautiful videos. Here is Sky, who is a key star actress who has the lived experience of intellectual disability. We have created Easy Read booklets and also decision-making tool and some key learning principles for healthcare workers using the quotes from people who talk to us what they need. And I just want to show an example. People told us that they want a person-centered story that really explains the whole process and shows the places where people can make choices to continue or not to continue, and how could that look like. I think what's important, many people talk about co-production and co-production with consumers more widely. And I think my concern is that often it means that there is only, for example, one person involved who has the lived experience, or the involvement is only at one step at a time. So just to create this toolkit took us 2 years, and I'll just very quickly show the journey where we had altogether 5 co-production workshops with people with intellectual disability, each of them attended by around 15 people, and of course facilitated by our beautiful Julie Lobbins-Refalo, who OAM, who received the Medal of the Order of Australia for her service to people with disability, and she's the best facilitator. I wish I could do half of good job as she did. So we started with the first workshops. We drafted resources based on what people told us. We went back to the co-production workshop, both with people with intellectual disability and healthcare workers. I can tell you, people with intellectual disability shredded our effort into pieces, and rightly so. So we went back to so this is again a timeline of coming back, drafting the new version of resources, doing videos, consulting with advisory committee, having another co-production where we were further reminded of things we need to change and make better. Then we had 4th co-production with people from rural area or people with intellectual disability. We then went back to the drawing board, again revised the resources, made additional video that was needed as we were told, and then came back and celebrated with people what they helped us to create. And that's really important thing, that the consumers often come and tell us, look, people come and they use us. And this is often experience of people with intellectual disability. Researchers or teams come to us, ask questions, and never come back to tell us what happened with the information we gave them. So this is just an example of how the co-production can look like and what it can achieve.
Thanks so much, Iva.
Thank you. I'm going to talk to you today about a small piece of work that's coming out of a much bigger project that I'm currently working on in partnership with Carers New South Wales and also with Catholic Healthcare, which ultimately hopes to design and pilot new models of respite or replacement care that meet the needs of working carers. So the presentation today is really just a very small piece of that project, where we've had a look at, well, if we're designing a new model of respite or replacement care, what are others doing in the space of innovation when it comes to respite care? So we have developed a paper reviewing what's happening internationally when it comes to innovation in respite and how people are talking about respite and how people are talking about innovation and what it means in the context of respite. So we've looked at what are the scope and characteristics of service innovations in respite or short breaks for unpaid carers and the people for whom they care. Next slide, please. So just briefly, we did a large literature review. We screened thousands and thousands of studies and ended up with 41 studies within our period that we were looking that focused on innovation in respite. Next slide, please. So just briefly, interestingly, there are the most papers in the United States there focused on innovation in respite, followed by the United Kingdom. And we have colleagues in those countries who are involved in that innovative work, followed by Australia, and you can see the remaining countries listed there. Most studies were qualitative in nature, so mostly interviews and focus groups with carers and people receiving care who had used innovative respite services or who had provided them, talking about the service innovation and its effectiveness. But there were also a number of mixed methods and quantitative studies as well. Next slide, please. So we've developed a bit of a sort of topology of the innovative elements. Now, it's important to say that there were some kind of dimensions of the service models where there didn't appear to be very much activity. So, for example, the duration or timing of respite was notably absent from discussions of innovation. So, what time periods, how flexible the timing was, what time of day, how the time was organised around other activities. That was all something that was pretty quiet in the literature on innovation in respite. But there are sort of 4 areas that we've focused on, 2 on this slide and 2 on the next slide, where we've really seen a kind of concentration of innovative activity in the area of respite. The first one is what we've called the kind of overall approach or orientation to the respite. So we found a lot of literature about personalisation as being an innovative characteristic focused specifically on and flexible to the needs of the carer or the person receiving care. We had a number of papers discussing a whole family approach to respite provision, and I'll come back to that because that's the specific example I'd like to focus on. We also found quite a bit of discussion about philanthropic and volunteer-based models to respite. So this was really things like approaches to respite that relied on donations of time, resources, or experiences or activities by organisations or philanthropic trusts that enabled the respite to be funded and provided. Then we had place-based or community-integrated respite approaches. So these were approaches to respite that were really focused on embedding the respite service within the local community context and engaging local community stakeholders in the provision of the respite program. And then there were a number of peer-to-peer style respite programs and cooperatives where people banked their respite and shared respite in different ways between different groups of carers. The second area of innovation was in the provider. So, I mean, some of these things don't sound all that innovative. We know that we've had, for example, host family respite in Australia for some time. But this is what is described as being innovative in respite over the last 20 years. And so we had a number of volunteer-led programs being described as innovative, a number of peer-led programs, so respite provided by other unpaid carers to unpaid carers, respite provided by students or recent graduates, and forms of respite that were provided by technology, where technology assumed the role of provider. So that was things like virtual reality style respite programs, social robots, apps, and including music style apps that are designed to provide activities for the care recipient in a way that may provide a form of respite from the care relationship for both the carer and the care recipient. Next slide, please, Lucas. So the last two kind of aspects of the framework were really the kinds of activities that were done in the respite context and the setting or location of the respite programs. So we had a very large amount of our papers in the sample focused on engagement in art and music-based programs, sometimes art and music-based therapies. We had respite organised around tourism and travel, fitness-based respite programs, providing fitness activities either for the carer or for the person receiving care or both. Nature-based respite experiences, including visits to things like green farms, bushwalking. We had volunteering opportunities offered to carers and people receiving care, so participating as a volunteer as a form of respite, and more traditional respite activities, but provided through or facilitated by technology. And just finally, in the setting and location, we had things like arts venues, nature-based settings, tourism and recreational experiences, and virtual or online spaces as being the site in which carers and people receiving care were participating in the respite activities. So that's kind of the framework of the 4 areas of innovation where we really saw concentrated work in this study. What I'd like to quickly talk about is the impact. So one area that I want to kind of call out and focus on in terms of the difference it made for carers is the area of the whole family approach. So we had a number of studies that talked about taking a whole family approach. And we actually divided this into 2 different types of whole family approach. There's what we call a shared approach, where the carer and the cared for person participate together in a respite program, or a whole family participate together in a respite program in a shared way, where the shared needs of the family are identified collectively, like the collective needs, and they participate together in the same program as a form of respite. The other is what we called concurrent approaches, where the needs of the carer and the needs of the cared for person are assessed, and those different needs are met through different kinds of activities that occur concurrently. So, for example, one program provided an arts program for carers, which went for several hours, and the cared for person had a lunch in a restaurant with some peers. But what these had in common was that the intake process was really focused on the needs of both the carer and the cared for person, and sometimes the broader family. And this really had, very strong positive outcomes for carers and people receiving care. as you know, many of our systems are kind of siloed, and so even if a program is really meeting the needs of a cared for person, for example, they might have a therapeutic intervention available through an NDIS package, and the carer has a couple of hours to themselves while the cared for person is participating in that activity, but that might not actually be meeting the carer's needs. And on the other side, there may be a respite program designed for a carer's specific needs, but if they don't think that the activity that the cared for person will be involved in while they're participating in the respite is adequate or of high quality or meets the needs of the cared for person, they won't use the opportunity for respite, even if it's designed around their needs. So what was really which really led to the positive outcomes for these whole family approaches were taking into account both the carer's needs and the needs of the cared for person. And this was enabled by flexibility in the structures that sat around, often the funding structures and infrastructure and the workforce that sat around the provision of the respite program. Thanks.
Thanks so much, Myra. And then we'll just hand over to Holly, and then we'll hopefully have a little bit of time for some panel questions at the
Great. Good morning, everyone. My name is Holly Hoskisson. I am the Care Support Team Manager with ARAFME. ARAFME is the peak body for mental health carers across Queensland. And I'm delighted to be here this morning to be able to talk about our Carer Respite Hub and thank the previous panelists for their informative presentations. Hopefully what I'm about to share will complement what's already been discussed and what's happening elsewhere. I am speaking to you from Meanjin today, and I'd like to acknowledge the Turrbal and Yugara peoples as the traditional owners of the land where I am today and pay my respects to elders past and present. So as I mentioned earlier, ARAFME is the peak body in Queensland for mental health carers, and we deliver a wide range of services to carers across the state, including a 24-hour carer support line. We deliver one-to-one support, workshops and information sessions, and we have a carer gateway program team across the state and also a carer support team program funded by Queensland Health. And today I'm going to speak to you about our beautiful Carer Respite Hub in Inner Brisbane. And the photo that you can see here is from the veranda of the hub. So the ARAFME Carer Respite Hub offers a residential respite service designed specifically for mental health carers in Queensland. So the respite accommodation is not for the person that the carer looks after, it is solely for themselves, their friends or their family members. And just note when I'm talking about carers here, I'm talking about friends, family, kin, and however those who access our services identify themselves as. So the hub is located in Tenerife in Inner Brisbane, and it opened in November 2023, and it operates as a distinct service within our broader carer support programs for mental health carers. It is a dedicated 3-bedroom, fully accessible property where unpaid carers can stay by themselves and have a break just solely by themselves, or they can come along with friends or family members. The hub is staffed. We have 2 full-time carer respite coordinators who are funded by Queensland Health and Wellways Carer Gateway, and they staff the hub and pull all of the breaks together and provide support to carers when they're staying. Since November 2023, we've had 430 carers access respite, and we've had 1,010 nights of respite delivered. So carers can come for a break for up to 3 nights, and we've had carers come from across Queensland to access the support. Here is a photo of the respite accommodation. So here you can see the kitchen area, the fully accessible living spaces, 2 of the bedrooms and the back terrace. So very much really high standard decor, quality services. And the whole idea is that the hub is to replicate a home and not a service provision or facility. So when we're talking about innovation and best practice, I really wanted to highlight that something that's been shared with us is that the Carer Respite Hub model is more than a place. What makes it accessible and effective is a set of interdependent elements that together create the conditions for carers to feel seen, supported, and connected. And there's some key points that allows us to do that when we're providing a break for carers. So it's the purpose. What makes our Carer Hub unique is the purpose. It is just for the mental health carer, and the experience is designed solely around their own individual needs and circumstances. So our Respite Hub coordinators will do an intake, which I'll talk about later on. They think about the carer's journey, where they're at in that space. They'll assess very much from a trauma-informed practice perspective around what the carer wants to gain from having the break, what they need to put in place to be able to get there, acknowledging that it is difficult for carers to be able to have a break themselves and put things in place for the person that they look after. And it's very much taken at the pace of the carer as well. And it's really great to see and hear carers' feedback when they realize that the break is solely for them, because as we are all aware, carers spend so much time thinking about everybody else, but are very much in need of a break. So the physical environment is really important. And as you've seen from the photos, our hub is designed to feel like a home, not a service setting. So everything is really considered in terms of how the house has been decorated. Everything is to a high standard. Caterers have commented on the lovely decor. It has a really calm feel to it and a calm design. When caterers arrive, they arrive to a stocked pantry. So we have all the basic foods, essentials that they need. And also they arrive to a welcome basket, which is tailored to their needs around if they want to maybe have a pamper session when they're there, if they'd like some fresh bread and fruit and vegetables, to be able to cook some of their own meals. And we also have some kind of mindfulness and calming activities for them, such as kind of watercolor painting and different activities around that. The staff relationships make the hub what it is. The feedback consistently suggests that caterers don't just attribute the quality of the facilities, but also the quality of the experience that the staff provide. So that's to do with the welcome. So caterers are made to feel very much at home. It's their space. So the way the house is structured is we have a small office space downstairs, but upstairs is purely for the caterers. Staff don't go up there other than the respite coordinator, and that's just at the start of the break to welcome them in, do the kind of introduction and show them around. And then the staff are there to do check-ins should a carer need it, provide one-to-one support should a carer need it. But also if a carer just really wants their own space and time by themselves, they have upstairs come solely to them by themselves, which is really great to see. And many of our carers spend time kind of just resting, catching up on sleep. A lot of the feedback talks about the peace and quiet and doing things that I think a lot of us take for granted in terms of having a meal to themselves without being interrupted or not having to cook for someone else. And it can feel at times overwhelming for carers to have that space. So it does take them a little while to settle into the Respite Hub. And not be looking after lots of different people or having lots of people talking to them, particularly in that mental health carer space where it's very episodic and our carers are really frequently in a heightened state of anxiety. Coming into the hub to that peace and quiet and that calm is very much what's needed. I mentioned the intake before. That is genuinely where the experience starts. So when a carer is referred to a RAFME for respite, the coordinator does an intake, really talks to the carer about what they need, what their caring circumstances is, how they're traveling in their caring journey right now, and what they want to gain from their respite stay with us. What that looks like. Is there a good date or time of the year that they want to access respite? Who look after the person that they care for? What concerns would they have in staying at the respite? How can we support that carer to overcome them? So there's a real process and support kind of procedure in place and support process in place to make sure that that carer can arrive and get the most from their break. And we have a connection to the broader ecosystem. So as I mentioned before, the Respite Hub is a distinct support service across ARAFME, but we can connect carers to our other supports as well, which means after their break, they can continue to get support in their caring role. So in terms of how the hub overall kind of contributes to the field of mental health and addresses some of the needs, as we're all very aware, the most significant impact on caring responsibilities and is reported widely, documented widely, is on the carer's emotional well-being. So almost half of 300 respondents to a recent ARAFME survey experienced their own mental health challenges. And that's around burnout, exhaustion, levels of anxiety due to that mental health caring role. And carers often have reported to us that they face financial disadvantage. So being able to fund a break themselves isn't an option. The Carer Respite Hub that ARAFME provides is free. Carers have to provide their own transport to get there, and then they need to kind of fund meals and things while they're at the hub. But other than that, there's no cost to the carer to be able to stay with us. Mental health carers experience stigma and socialization, isolation, and they do often struggle to get a break from their caring role, which is why the Carer Hub really addresses those needs. The 2024 National Carer Survey showed that less than 20% of responding mental health carers had access to a break, and 44% of carers within a recent Queensland survey stated that they reported that they had an unmet need for planned respite. And it's important to note that the majority of people within our care respite, this is planned respite rather than emergency respite. And the hub very much addresses that need. I'm ahead of my slides. That's good. I've mentioned before that we very much take a trauma-informed care approach to all of our services at ARAFME, but particularly Respite Hub. So staff use their understanding of mental health carers to assess and jointly plan the stay with the carer, to really kind of discuss any concerns they may have about coming to the break, what they want to get from it, as previously mentioned. The respite coordinators respectfully and sensitively explore what is happening for the carer at the time. Carers are giving a welcome pack. All carers have personal door codes that are changed after every break. We have an on-call system as well. So even when the respite coordinators have finished for the day, there's a contact number that the carers staying in Respite Hub can call if they need support or if there's anything that they want to ask in regards to the respite. So again, that unobtrusive support is always there. So carers can access it as much or as little as they need. They know that one-to-one support is available throughout the day. And that really provides reassurance that and really speaks to the fact that it can be difficult for carers to access a break, but they have these safeguards in place should anything happen while they're there, and we can navigate with the carer around how to overcome those challenges. We've had a wide range of carers accessing the support. As you can see, we had 430 carers within that time period up until the end of December. We've had siblings come. We've had like husband and wife come, partners come. So really kind of a wide range of services. A wide range of carers can have access to support and gain lots of different things from coming to the hub. And I just wanted to end by just sharing an outcome that was shared by a carer. The kindness and generosity extended to us by ARAFME staff members has genuinely and deeply impacted us. You have given us space to breathe and to be a family without the weight of stress pressing in. And that's very much something that we are proud of and hope that all carers experience when they come to the Respite Hub.
Thanks so much, everyone, for sharing the wonderful innovations that you've been working on. I thought what might be the most important of the kind of follow-up questions is the work that you've been doing across all different sectors has been great, but what policy change would unlock greater impact for the initiatives that you're leading or enable system-wide change or enable greater success of these projects? If there is any kind of policy or system change that you think would support these to build on these or be more successful. And I'll just open that up to the floor. I don't know if anyone...
Mel, I'd like to say I was listening yesterday to some of the presentations, and there was mention of a carer or a care partner identification card. And I do think that's something that would be useful. It's something that's been talked about a lot at different local health districts and at the Ministry of Health carer program. On the Central Coast, we're actually about to launch a project around a carer identification card. So testing it, orientation packages, identification recognition partnership in the hospital. And we were fortunate to get funding from Kind Lab through the experience team with the Ministry of Health. So I do think having an actual card for carers to be visible like any other staff member that makes them part of the care team would certainly open the doors for more inclusive care, more respect, and I guess better outcomes for everybody.
Just realised I'm on mute. Some of that really important work that you've been doing, enabling that visitation policy, if people had access to some sort of identification card, might be a lot more straightforward than having to kind of try and work out how to prove or provide evidence for carers. Eva or Myra or Holly? Myra?
I was wondering, I think one of the things we know that carers get such a high burnout when constantly advocating for their loved ones, but also having to re-explain medical information that is often really not their role or shouldn't be their role. And so I think having accessible information, that would be one of the things that I would see as really important change. In terms of looking at the policy, I think co-production needs to become not just a special call by funding bodies. It needs to be mainstreamed and embedded and be just expectation for anything that we do. And lastly, there needs to be, of course, real funding aligned to that. So we cannot say that we cannot say we give you 5,000 to do co-production. That's absolutely unrealistic. Thank you.
Great, thanks. And Holly, I can see your hand is up as well.
Thanks, Mel. Yeah, I would just agree with what been said earlier. I think I'd noted down kind of earlier identification and carer journeys is really paramount. And I've to speak to Tia's point, I've worked in the UK on identification card models that have been really successful in pilot areas, particularly in the health space. And also from a mental health carer's perspective, I think it's that support to navigate complex healthcare systems. We have a lot of carers that phone our carer support line to say the person I look after is going to be discharged from hospital on Wednesday. I don't know what to do. I'm not ready, and I don't know who to talk to. So I think there's need for real significant support, which we ARAFME and other organisations do, but to really help carers understand and navigate those complex systems.
Yeah, definitely. I think that navigation piece is a huge thing we tend to see, and having improved navigation to these programs and projects that are available, or to these key policies, also really helps with carers to access them and use them effectively. And Myra?
Yeah, I mean, I think certainly when it comes to innovation in respite, currently the funding models aren't fit for purpose. They, what is required to enable innovation to flourish is like consistent, secure, ongoing funding so that services can experiment, they can take risks. They need funding guidelines that are flexible. So, for example, during COVID, some of the Commonwealth Home Support Program providers, daycare providers, were really innovative because of the relaxation of some of the rules around their outputs, which enabled them to try new things and focus on meeting needs rather than very rigidly defined kind of output reporting. So greater kind of security and flexibility in the funding systems would really enable people not only just to try innovative models of
Yeah.
respite, but to sustain them beyond the initial pilot phase, where often,
Yeah.
you know, it works, but it drops off because
Yeah.
there's no funding there.
And I think that's one of the key challenges, is that we see so many of these good innovations happen and then kind of they aren't able to be continued on. I think funding's a really important part. Is there anything else that helps with maintaining these or building on these projects and learning? How do we kind of take them forward? Is there any pathways that you see, Eva or Holly or Tia, with growing on what you've kind of got at the moment, or Myra? Yeah.
I mean, I think the another issue is that there's sort of, because the systems are quite siloed, it makes it difficult to do innovative work that sits across systems, and, you know, families sit across systems. You know, people's experience of care aren't siloed. I think also opportunities for systems to work together in the delivery of programs would ultimately enable kind of small scale pilots to be scaled up in ways that are
Myra, I
effective.
was just absolutely thinking the same thing. And we just an example of the work that we have been working on. We know that students with intellectual disability should learn about health literacy, but yet they are not taught because of many reasons, such as underestimating their capacity to understand. We know carers need health literacy to get through the journey, but we also know that healthcare workers are making assumptions, and we could work really nicely together if we bring all of these parties together. So it was fantastic point. Thank you.
Yeah.
I think as well, speaking to the funding piece, Mel, I think that's why we feel really fortunate that we've got ongoing funding from Queensland Health and Care Gateway to keep our hub running. But it's the only one for mental health carers in Australia, and certainly from Queensland, we're only in Brisbane. So I think it's about for when we have good examples of good practice sessions like today, and really sharing the impact and outcomes of what's been delivered and why that's important. But I think it's also then looking at what are the barriers to carers accessing it, and how do we then look at those policy pieces as well in terms of access to respite for the person that they're looking after, so that they can actually come and have a break themselves. So I think there's two things in parallel, really demonstrating the impact it can have and why it's so needed, but also how do we also look at the other piece in terms of the person that they look after.
Yeah.
I guess I'm going to talk from two different perspectives. I'll put my hat on as manager of carers support at a local health district with Ministry of Health. We have carers support teams in every local health district across New South Wales Health. We all work differently. We're all funded the same to start with, but some services have lost funding, other services have kept it. On the Central Coast, we've actually started, every time we consult a carer, we actually record that, we document in the medical record, and we record that as activity, just like any other clinician would. So we're raising the visibility, the value of what we're doing. That doesn't happen everywhere. So now here, we generate what's called NWOW, Non-Weighted Activity Unit, which is how the districts get funded. So we're actually showing we're doing work, really valuable work, raising the visibility of carers. And I think if we did that across the state, no matter how few staff we had and no matter how few consultations we did, that visibility is there. It's also in the records, so people know that is a person who is caring for someone and has their own individual needs. Then if I put my hat on, having worked at the Ministry of Health with the visitation policy, the thing I love the most about this policy, it went out with an implementation plan. It went out with questions. It went out with supports. So it's got a SharePoint site for staff to go to see what's happening everywhere else. And it's amazing what is going on. When you talked about siloing, you look at this site, there's so many amazing initiatives and innovations. There's also Kind Lab that's actually funding new initiatives and innovations. So getting that more out in the community about what we're doing. In terms of the implementation plan and the questions, one of the key things is when LHDs, when local health districts get the policy, they should be co-designing procedures and practices. So it should be with carers, consumers, staff, everyone. And on the coast, we're actually hoping to have the Living Lab, Central Coast Living Lab, run a co-design to actually look at what works for carers, what works for consumers, what works for staff. Let's design it together so that we all own it. So they're my 2 cents.
That's a lovely way to kind of, I guess, summarize some of those real opportunities that exist when it is kind of done well, with that policy implementation and how we do overcome some of those barriers. And I think, the more opportunities we have to share and learn from each other is just such an important opportunity as well. I think everyone's doing so many amazing things, and we don't always get to see or think about how those apply in different spaces. So it is great to have everyone here today. I'm mindful we are over time, so I will say thank you to our speakers and thank you to everyone for joining us this morning, and for our panelists and speakers for sharing their knowledge, insights and experiences. We feel that today's discussion highlighted important examples of policy and practice innovation across the sector, across the carer space, while also reminding us of the work that still needs to happen to improve outcomes for carers and the people they support.